Hi, everybody. As Anna said, I work at Brigham and Women's. I'm a behavioral neurologist, and I work in a number of different areas, but brain health, overall concepts, and interventions is an area of interest of mine. I'm going to talk today about kind of what I see as a treatment gap or delivery gap in our knowledge and in our implementation. I want to start with kind of the main message and then kind of work back a little bit. The way that I think about it is that we know a good amount about brain health. You know, there's a lot of research to be done. There's ongoing research that we need. It's not perfect, but it's actionable. And what I mean by brain health here is general behaviors that are good for the brain over time, both for healthy people and for people with neurologic disease. You know, what activities can we do to build cognitive reserve, to promote optimal cognitive functioning for those that are healthy? What can reduce the risk of cognitive decline and dementia? So again, we know many things. There's consensus on many of these things, but what we know less about is implementation and delivery and achievement of these. And this is both in the health system and without. And I think that that's an important point, that if we're going to get to overall improved brain health in societies and communities and however we want to slice and dice it, we have to think about actual implementation science and how to do it. Thus, there's a gap between not perfect, but actionable items related to brain health promotion and implementation and delivery. And we'll talk more about that. So overall, brain health defined and talked about in different ways. I liked this description from the World Health Organization, an emerging concept that encompasses neural development, plasticity, functioning, and recovery across the life course. And I think that's important because we think as clinicians, and of course that we, many of us, myself, see older individuals, and we think a lot about dementia risk reduction and, bending the curve of age-related cognitive decline. But of course, building cognitive reserve across the life course is extremely important and plays into this concept of promotion of brain health. And then good brain health is a state in which every individual can realize their own abilities and optimize their cognitive, emotional, and psychological functioning to cope with life situation. So this is resilience, reserve, taking people from wherever they are, say they're at, 80% of their potential mentally, educational attainment, whatever it is, promoting those individuals to realize their maximum potential. So I think about this as two things: for the healthy to stay healthy, to continue to stay healthy, and for the sick, for people who have neurologic conditions or early neurologic disease, to improve their brain functioning, to try to reduce, to optimize where they are as best as possible, and to reduce further cognitive decline. Okay, and to give some perspective, for people may know that neurologic conditions altogether are the leading cause of disability around the world, this DALY metric globally, and that they're the second leading cause of death globally, accounting for 9 million deaths per year. And in looking at the statistics, it's mostly because of stroke and because of complications of dementia. When you add those two together, neurologic conditions are in that category. So this is important at all different levels, right? Globally, locally, et cetera, and for a lot of reasons. So people may know that there's a number of initiatives, enterprises, partnerships addressing brain health globally. Some in name or in effort, but with less to show yet for it, and others with a lot of things going on that are trying to move the needle on brain health. So there's the Global Brain Health Institute, this philanthropically funded enterprise that takes part of or involves faculty at Trinity College Dublin and UCSF, that takes fellows of all different backgrounds and trains them and partners with them. And people are the idea is people are dispersed and promoting education and brain health around the world. There's 150 plus fellows that have come in from different backgrounds to this training, this partnership, the GBHI. There's the Worldwide Fingers Network, which are the set of trials that are the follow-on studies from the Finger study, which was the intervention, multimodal lifestyle intervention out of Finland. People may be aware of that, demonstrated improved cognition, basically reduction of dementia and cognitive impairment in cognitively healthy at-risk older individuals. But the Worldwide Fingers is a set of ongoing trials around the world sponsored by the Alzheimer's Association that get at multimodal lifestyle interventions to reduce cognitive decline. There's the CDC's own initiative in the US called the Healthy Brain Initiative, which has a lot of different facets. And I was realizing is probably a whole nother discussion, merits a whole nother discussion. But briefly, the mission for the Healthy Brain Initiative is to create and support partnerships, collect and report data. There's a roadmap related to actionable items, both like at the public health level and the education of within the health system level. And there's a lot of funding for this. There's centers of excellence that are identified. You can apply for grants as a center to get resources and funding to promote brain health. So there's global and local national efforts in brain health. So, but I kind of asked, what will be the specific programs and interventions? So you can educate and empower clinicians, and we should do this, primary care, all the touch points of the healthcare system. But it's also a challenge to think about how to implement and have people adopt and maintain brain health behaviors generally. So what evidence-based knowledge about brain health and dementia, and also dementia risk reduction as part of that, do we have? So there's consensus from, as people in this audience probably know, from a lot of population-based and cohort studies, that there are many behaviors and several that there's more consensus on that reduce dementia risk. And for clinicians, this falls into what we think about in our treatment or counseling as the non-pharmacologic lifestyle interventions. And in fact, if you look at major institutions like the Institute of Medicine, the National Academy of Sciences, the WHO, the Alzheimer's Association in the US, the American Heart Association, and more that I didn't list, there's guidelines and recommendations based on their own scientific review of the data in which there's a lot of consensus on what needs to happen. Again, not perfect, but actionable, right? We don't have to wait longer to think about the ways to reduce the burden of cognitive decline until things are perfect, right? So just to highlight that, these are 6 organizations up here, and in the list are these various different activities, behaviors, activities, physical activity, cognitive stimulation, education, social engagement, medical things like treating cardiovascular risk factors, diabetes, managing stress, depression, et cetera, things that people will be familiar with, generally speaking, limiting alcohol use, et cetera. And then I kind of highlighted that like these two, physical activity and treating cardiovascular risk factors, have a 6 out of 6 consensus for these 6 organizations that I chose that have these mission statements and white papers and everything. And then there are several more that have 4 out of the 6 or 5 out of the 6 in which there's consensus. So basically there's consensus from professional organizations that are involved with guiding clinicians and public health initiatives on behaviors, right? So the other ones like heart healthy diet or brain healthy diet, maintaining healthy weight, countering the metabolic syndrome, stopping, reducing smoking, et cetera. These are, there's consensus. And interestingly, for other discussions, there is not full consensus, or at least there might be omitted in these recommendations and guidelines. Some of these other things appear in some of these organizations, but not others. So it's an interesting topic to come back to, but generally speaking, there's consensus on many of them. So health systems are also not the only place for us to move the needle on brain health, right? So I was hinting at this before, but especially for those with higher risk of the social determinants of health. So community and civic organizations, like policy and programming, is important at that level. Public health campaigns, of which there have been some in the US, for example, led by cities, towns, municipalities, are important. And there's the idea of national brain health councils, which get at education and public health initiatives as well. And I mentioned programs like that, what is being trialed in the US Pointer study, which is a follow-on study from the Finger study, which is enrolling now. That kind of trial, which involves YMCAs, local senior centers, community organizations, allying with the health system, that kind of trial, if successful, could be mimicked in a program, in a wide-scale program. So I'm optimistic about that, that's a real world pragmatic trial, basically looking at the ways to actually have people from a population level, like large level, adopt and maintain these behaviors. Okay, so just to talk a little bit about within clinical care and what's the genesis of the particular effort that we're doing at the Brigham related to brain health promotion. So what is the treatment gap in clinical care? So despite knowledge about brain health and dementia risk reduction that I described, generally we have found that there's suboptimal dissemination and implementation through these different touch points in the healthcare system, of which we in an academic center, or of course the specialty memory clinic, are only one touch point. We see patients as our providers at colleagues, you guys in Mass General, also who have been through primary care or geriatrics or general neurology. And so what is the problem? So there's just a challenge in implementing these recommendations and having people achieve and adopt these behaviors. And this was kind of the genesis of what we called the Brain Health Champion Study, with kind of discussions going back a couple of years now. And mainly from observations that even our most well-intentioned and connected patients who may need the least help in achieving brain health compared to others, still would come back and see us in clinic that say they have mild cognitive impairment due to early Alzheimer's or suspected Alzheimer's, right? And then they're not achieving the recommendations, the treatment. So you finish a clinic visit, you identify someone has mild cognitive impairment. There's no pharmacologic meds at this time. And the treatment is really brain health, non-pharmacologic lifestyle interventions. And we know that there's an evidence basis for reducing both personal risk and, like, from a population level of dementia incidence, right? So people are just not following these things, and human behavior is hard to change. If we can agree on one thing, we can agree that having people understand and adopt and change behavior is complicated. So it's kind of like, I see it as a theory versus practice dilemma in some framing of it. So you have, exercise recommendations for exercise, brain, heart, healthy diet, cognitive stimulating activity, sleep integrity, sleep quality. And all of these things, at least in the health interface, come out, as the treatment or recommendation guidelines in a neurology clinic visit. And it's a lot. It's a lot to hear. It's a lot to understand, especially if you personally, as a patient, need to move on a lot of these things. And so you kind of like hit a wall, in a sense, for many people, not sure what to focus on. And so, but there are ways to understand how to change behavior in a better way, and to do it in a better way, so that people have achieved incrementally progress, concrete progress over time. And that's also kind of the framework and the background for coming up with a clinic embedded brain health promotion program, basically, which is what the Brain Health Champion Study is. So in the first cohort of patients brought through, the study design was as follows: 6-month randomized controlled trial. So 40 patients were identified in our behavioral neurology clinic at the Brigham. Of these 40, 15 had mild dementia due to mostly AD, but I believe there were a couple Lewy body and other mild dementia cases. 21 had mild cognitive impairment, and a couple had subjective cognitive decline. And there were 2 arms of this initial cohort. This was a low technology, what I call the low tech first cohort. So patients and caregivers worked with essentially in the intervention arm, the health coach arm. Patients and caregivers worked with an additional clinical team member, someone who we as staff trained as a health coach, and termed the Brain Health Champion. And that intervention was simply weekly motivational interviewing calls, so phone calls with enrollees based on principles of motivational interviewing and establishing rapport, and then carrying people through a kind of brain health curriculum, in a sense, over 6 months. And those folks initially had in-person visits every 6 weeks when this was pre-COVID, and we had to adapt the second cohort, which I'll describe in a minute, but we saw them in person every 6 weeks. So 3 times over the course of the 6 months. And then we did weekly phone calls. And then there was a focused counseling session with a research dietitian who we worked with at the Brigham. And that arm was compared to a control arm, which was the standard of care arm. And the idea there is that whoever the referring neurologist is or was, would just continue as they normally would, see the patient, counsel the way that they would normally counsel, right? So what I say might be slightly different from what Zaina says, or what have you. I might spend 5 minutes and someone else might spend 15 minutes, just whatever the usual care is for these patients that was happening. So the study outcomes for this initial cohort were just self-report measures in the main tenets of brain health that we identified pre and post 6 months, which were physical activity as measured by the IPAC, dietary pattern, adherence to Mediterranean diet by the Medi score, and then cognitive and social engagement or stimulating activities as measured by a validated cognitive activities scale. And then some secondary exploratory outcomes were quality of life, general cognition, just by MMSE, neuropsychiatric status, sleep quality, and social network size. Okay, and these 40 patients were fairly similar across the 2 arms. So these are people in their mid-70s, fairly evenly split by sex. The diagnoses I mentioned were a little bit more MCI, but some had mild dementia. And I think it's important to note that both in this cohort and the ongoing cohort that spouses, caregivers, in the case of people mostly with mild dementia, but some late MCI, played an integral role in, participating in telephone calls and supporting their spouse. And that's different than a cohort in which people are cognitively normal, and you're delivering a similar intervention. And then there was some people were, mildly impaired based on baseline MMSE stats. So generally speaking, coaches would divide over the 6 months and focus in different time periods: physical activity, diet and nutrition, social activity, and cognitive activity. And I think the key is this was personalized. In this model, it was a one-to-one coach. Coach had many participants, but the counseling was done by phone, in a one-to-one model, focusing on these things. And I want to make sure we have enough time to talk too. And so some behavior change techniques that the coaches were trained on with our help and with the help of a colleague in psychiatry as well were motivational interviewing, eliciting change talk, initially especially to understand where people are at as far as change, and then behavioral activation techniques, which is just really coming up with actionable goals, short-term goals, holding people accountable to those goals over the course of the intervention. And then just large scale, just kind of structurally, some structural changes in their lives sometimes, making sure that, they chose one activity to do in the morning before anything else started. Or my classic example of this is putting on your gym clothes when you get up in the morning before you do anything. So you have to work out. That, those are kind of some small kind of behavioral economics principles applied to behavior change in health. And so I can skip over this, but this is an example of success in this cohort. So 67-year-old woman with mild dementia who was in the active intervention arm, like increased physical activity, increased cognitive activities, things like weekly Tai Chi class. This person had not been doing exercise before, took 2 to 3 weekly brisk aerobic walks per week, for example. And on the right, an older man with DLB who there was some focus on medical stuff like adherence to CPAP for his apnea and involvement and kind of improved diet. So the study results were pretty great for this low-tech telephone intervention. So, there were large effect sizes, the magnitude of the change. So green, you can see here these measures, Mediterranean diet score, exercise, and cognitive activity scales were the 3 self-report brain health behaviors that we measured pre and post. And of course, these are self-report data in this first cohort. But the green line represents over time the intervention, the health coach intervention, and the yellow line here is the control. So there was, some, I think, clinical meaningfulness and statistical significance in exercise and cognitive activities, and in quality of life measures over the course of the 6 months between the 2 arms. And then let's see. So then I'll just move to this. So now that we're enrolling a second cohort, so there have been 27 completers to date, 34 totally enrolled, 45 patients. So similar model, 6-month randomized trial, this time involving a mobile health platform. And this actually worked out well for COVID in a sense, because the whole protocol was virtualized and we were able to ally with a mobile health platform external to MGB, but that allows the coaches to communicate by video and mobile messaging. And I would love, we can talk more about that for people interested in digital health. So the digital health technologies were adopted very well by this population, age 60 to 79. And what we did in this, and what we're doing in this, this trial is involving people within individuals within primary care as well. So those who have risk factors as identified by the CATIE risk score, similar to what was used in the finger study that I described earlier. And so there's both patients with from primary care who are cognitively normal at risk, but also people who have MCI from the clinic. And so, and these folks are also wearing wearable fitness trackers using Fitbit to quantitate exercise, the best that we can obtain at 2 time points, 0 and 6 months. And they also photograph their food logs at assessment. So the preliminary results are pretty good for these 27 completers so far. This is unpublished data just to share. Feasibility, which is kind of one of the main things we're doing in this pilot, seems pretty good. People were operated all the different mobile technologies really well. Sometimes in the case of the MCI patients with a study partner. And it looks like, diet seems to have more of a change for the better improvement compared to the control arm. And, things to look at, but everyone seems to do better on cognitive testing over 6 months. This is a 6-month study. The idea of moving the needle on cognition is not really the goal for this feasibility study. You can imagine an intervention like this over 1 year, 2 years, et cetera. But that's kind of interesting. And then quality of life measures, as well as actual physical activity, seem to be improved in both the control arm and the health coach arm, which is augmented by the mobile technology. So just to end, so the idea here is just could be many different possibilities, you know, flexible, replicable interventions like this. Cohorts of, this is within the health system, you could have peer volunteers that act as coaches. There could be people like we used physician extenders or health coaches, you know, folks who were pre-health students who we trained as coaches. You know, at the Brigham, there are initiatives that use individuals like this called health navigators who work in primary care, who also check in on medications and things like that for patients. So, and the idea is that, that this can be scaled. And I think most importantly, across all socioeconomic strata, because I mean, the people who we need to help the most are those who are not accessing the health system in the same way as others. And so this is the larger vision of what this kind of program can do. So I know we're up on time. I thank you for your attention. I hope I did not leave any time for any questions, but maybe there's a time for one or two, I don't know.
Yeah, no, we have time for 1 or 2 questions. Any questions for Dr. Gale? If not, as we wait for the others, because I asked them to put it in the chat, I have like a couple of comments to share with you. So first of all, I think we're thinking similar, because we are doing the same thing at the McCance Center for Brain Health, even though kind of we don't have yet this randomized study for what you are doing. But as you know, we have our brain care score. And so a lot of what we do is also this motivational interview, because people come just for that. And we are in the way of like talking some more about having coaches that will talk to the patients and be involved and through the primary care physician as well. So this is really work in progress. And I am very happy to know that you started this study. As you said, the time span is very short. So we have to really make sure that people are maintaining those habits over time, because in the beginning, there is this honeymoon period, and then it can actually fade away.
Absolutely.
So that is one. And the second thing I want to like put a bit of a point for another study, and you might also be aware of it. It's for Dean Ornish study of the lifestyle and the nutrition. And I was thinking that some people of your cohort also could enroll with them. So keep them in mind. And if you don't have like a direct link to them, I could send you also their research assistant and stuff like that. And it is your cohort, because they want mild dementia and MCIs and followed over time for their diet, and then only have a caregiver with them. So that might be something else to also note.
Yeah, I appreciate that, Zaina. And actually, we've been connected for 1 or 2 of these completers already. Actually, it's great. Right. Thank you. Yeah.
Of course. Any other questions?
Yeah, if I can ask a question?
Yes, please go ahead.
So I just was wondering if you already from the data have an idea of what is better in terms of reaching the goals, to give them a lot of different things they can modify with the idea, you know, you might not be able to, you know, change everything, or give a more focused approach, you know, saying like, oh, maybe you should just focus on exercise. I can see working both, and maybe it's easier to change everything a little bit. On the other hand, some people might get overwhelmed and it's like, oh my God, like, you know, like my eating is wrong, my exercise is wrong. Like, do you have any idea, and how would you identify like what to start with? Or you think just throwing it all out there and then let's, you know, let them kind of make that decision?
Yeah. No, it's an excellent point. So I think the approach to date has been like one of very personalized, even though I suggested a curriculum, and the coaches have adjusted. If, for example, they start with exercise for the first 1/3 of the intervention and find that that's kind of what they want to focus on, then they've done that. They've extended, you know, the trial, the focus on exercise. Interestingly, in that first cohort, there was a synergistic effect of all the, if we did a composite behavioral score, which I skipped over quickly, but it seems apparent that when people are doing those 3 main activities, education, adherence, cognitive stimulating activities, adherence to Mediterranean diet, and exercise, that their their overall improvement on self-report scores is better. So there's a synergistic effect of doing maybe a little bit of each of them. Mm-hmm. But yeah, I think, you know, you can imagine a platform type study to identify where the, you know, what to focus on for profiling people in a way to figure out what you should focus on with them, even after the coach establishes rapport, meaning that you could have different arms where education is the focus for a several month period. And then, or, you know, diet, you know, is, education is first, et cetera. So I think it's a work in progress, but it's a very important point that we don't want the intervention to be like life, where they're overwhelmed in the first place. Yeah. Right. So I appreciate that. Thank you.
Thank you very much.
Thank you so much, Dr. Gale.